Hello everyone. In today's session, we are going to discuss about one of the most fascinating and one of the most interesting and important topic of the cardiovascular physiology, which is the cardiac cycle. When we talk about the cardiac cycle, we are referring to the complete set of events that occur in the heart from the start of one heartbeat to the beginning of the next. In other words, it's one full lub dub and everything that happens between those sounds. This includes both systole, the contraction phase, and the diastole, the relaxation phase of the atria and the ventricles. So each of these phases is precisely coordinated so that blood flows smoothly in a correct direction through the heart and out of the body. If the heart rate is around 72 to 75 beats per minute, each cardiac cycle takes about 0.8 seconds to complete. This might sound short, but in this time, the heart chambers contract and relax in carefully and timed sequence manner. So the key driving force behind all movement of blood in the heart is a difference in pressure between the chambers and connected vessels. We all know that blood naturally flows from the areas of higher pressure to the areas of lower pressure. So before we go into each phase of the cardiac cycle, first we must understand about divisions and durations of the cardiac cycle. When the heart beats at normal rate, that is of 72 per minute, I already mentioned you that the duration of each cardiac cycle is 0.8 seconds, which has atrial events and the ventricular events. For example, when we talk about the atrial events are divided into two phases. Atrial systole, which is of 0.11 second, and atrial diastole, which is of 0.69 second. So after the atrial events, we have to talk about the ventricular events too. So ventricular events are divided into two phases again. That is ventricular systole, which is of 0.27 seconds, and ventricular diastole, which is of 0.53 seconds. So remember that whenever we discuss about the cardiac cycle or in the clinical practice, systole refers to the ventricular systole and the diastole refers to the ventricular diastole. So in the entire phase of the cardiac cycle, whenever I am discussing about the systole and diastole, always think of the ventricles, and especially we are talking about the left ventricle in focus. So now let us discuss about the durations. I already mentioned you about the ventricular systole, which is of 0.27 seconds. And in this 0.27 seconds, we have two phases of ventricular systole. One is isometric contraction period of the cardiac cycle, which is of 0.05 seconds, and the ejection period, which is of 0.22 seconds. So these are the two events what we will see in the ventricular systole. And next is about the ventricular diastole, which is of 0.53 seconds. And this ventricular diastole has totally 5 phases, starting from protodiastole and to the atrial systole at last, right? So majority of the authors combine protodiastole with the isovolumetric relaxation, and majority of the authors do not mention the protodiastole period. That is the reason they start the ventricular diastole directly with the isovolumetric relaxation phase. But there is a clinically important points what we need to know about the protodiastolic period. That's the reason I want to include the protodiastole in the ventricular diastolic period. So the first phase of the ventricular diastole is the protodiastole, which is of 0.04 seconds. And next is about the isometric relaxation phase, which is of 0.08 seconds. And next is the rapid filling phase, which is 0.11 seconds. And after the rapid filling, the filling becomes slower, that is slow filling phase, which is of 0.19 seconds. And the last one, last rapid filling, it is nothing but called as the atrial systole, which is of 0.11 seconds. So these are the 5 phases what we will see in the cardiac cycle, that is a diastolic period of the cardiac cycle, right? So now, the total phases what we have in the cardiac cycle, 8 phases. So in the ventricular systole, I mentioned you that we have the isometric contraction, ejection, and ejection also we have the rapid ejection and reduced ejection. So totally we have the 3 events in the ventricular systole and the 5 events in the ventricular diastole. So totally we have 8 events in the cardiac cycle. Remember like that. So now we begin the cardiac cycle with the last phase of the ventricular diastole. I'll explain you why I am taking this last phase of the ventricular diastole first when I am discussing about the cardiac cycle. So now, what is the last phase of the ventricular diastole? Last phase of the ventricular diastole is the atrial systole. So remember that atrial systole is a very brief but important phase of the cardiac cycle, lasting roughly about 0.11 seconds, and it represents the final stage of ventricular filling before the ventricle contract. So during this time, the atria are actively contracting while the ventricles remain absolutely relaxed. When I said that the atrial contraction period is about 0.11 seconds, so what do you think is about the atrial diastolic period? Right? Atrial diastolic period is much longer, that is around 0.69 seconds, covering the rest of the cycle when the atria are not contracting. So 0.69 seconds, atria is completely relaxing and contracting only at 0.11 seconds during the entire duration of the cardiac cycle, that is 0.80 seconds. So now, how the sequence begins? The sequence begins when the sinoatrial node generates an impulse, causing depolarization of the atrial myocardium. So when this happens on the ECG, this depolarization is seen as a P wave, which occurs just before the atrial contraction starts. And this electrical event triggers atrial muscle fibers to contract, producing a mechanical phase. We call it as atrial systole. So atrial systole is not the electrical phase, it is the mechanical phase. Before the atria actually contracts mechanically, whatever the impulse which is generated from the SA node and distributed throughout the atria referred to as P wave in the ECG. Remember this point. So as the atrial walls contract, left atrial pressure rises. Because why I am talking about the left atrial pressure, why I am not talking about the right? Always whenever we discuss about the cardiac cycle, we discuss the pressure mainly on the left side rather than the right side. The pressure in both the left and right atria increases. But whenever I am referring to the cardiac cycle, I always focus on left ventricle and left atria. That's the reason I am mentioning it as left atrial pressure rises, producing a wave on the atrial pressure curve. See, I am integrating with the different curves, whether it is action potential, whether it is ECG, whether it is like atrial curve, everything I am going to correlate in this particular lecture. So this pressure increase forces the blood through the open atrioventricular valves into the ventricles. So the tricuspid valve on the right side and the mitral valve on the left side, right? So they are already open into the relaxed phase of the ventricles. And because the valves are already open during the rapid filling and reduced filling, now atria contracts, it kicks, so there is a sudden rush of blood, final rush of blood into the ventricles, right? So this is what we need to remember. So we already know that because there are no valves between the vena cava and the right atrium, right? I'm talking about the right atrium. There is no valves between the vena cava and the right atrium, or between the pulmonary veins and the left atrium. There are no valves. So what happens when the atria contract? So atrial contraction can push small amount of blood backward into these veins, whether into the pulmonary veins from the left atrium or whether into the jugular venous system from the right atrium. Anyway, the blood is coming towards the left ventricle and right ventricle only. But some amount of the blood has a backward flow. So however, this backward flow is very minimal because the momentum of the blood following into the atria from the venous system opposes any significant reversal. That is the reason the backward flow is very minimal and the forward flow is maximum. So this is very, very important for you to remember. Everything is integrated with some of the clinical aspects. So now, by the end of atrial systole, what happens? There is a final kick, final rush of blood is into the ventricles now. When I refer towards the left ventricle, the left ventricular pressure reflects what is called as left ventricular end diastolic pressure. Remember, when the ventricles are completely filled up, how they get filled? They get filled by three phases. One is the passive filling of the ventricles. During rapid filling, reduced filling, anyway, we are going to discuss that in detail later phases. But after the rapid filling and reduced filling is completed, the atria is going to push some extra amount of blood, approximately 25 ml of the blood is pushed into the ventricles, especially the left ventricle, on top of already 105 ml is already there in the ventricles during the filling phase. So 105 ml is already there, 25 ml is coming extra into the ventricles during the atrial systole. So the total volume of the blood which is present in the ventricles is 130 ml at the end of atrial systole, which is known as your end diastolic volume, right? So this is the maximum end diastolic volume we can say. And I can say that it can be ranging from 130 to 115. Athletes it is little bit more, but I am taking the common reference range values. So there is a total 130 ml of the blood which is present in the left ventricle after the end of atrial systole. The maximum volume of the ventricles will hold it during that particular cycle. So this end diastolic volume, this EDV actually determines the force of contraction which is exerted by the myocardium. Why? Because when atria pushes this 25 ml of blood into the ventricles, the ventricle muscle fibers stretch a little bit, right? So whenever the ventricle muscle fibers stretch little bit more when compared to that of the initial length, the force of contraction exerted by the myocardium will be much greater according to the Frank-Starling mechanism. That is the reason more end diastolic volume, more force of contraction, more will be the stroke volume, so more will be the cardiac output. This is how you need to correlate with each and every event. Now, I have already mentioned about what you see in the ECG, what you see in the interatrial pressure curve and all. In some circumstances, atrial systole can produce an audible fourth heart sound. This is not usually heard in healthy individuals or adults, but becomes noticeable in pathological states where the atria must contract more forcefully against a stiff ventricle. In what condition you will see the stiff ventricle? Ventricle is not completely getting relaxed when there is a push from the top, whenever there is a left ventricular hypertrophy, or whenever there is a scarring of the ventricular myocardium. The ventricular musculature becomes stiff. So the atria should use more force, more contraction force to push that 25 ml into the ventricular chamber, right? The scarring, what we will see in the myocardial infarction or in the left ventricular hypertrophy. In such condition, you will see that extra sound which is produced because of that atrial kick called as fourth heart sound. So fourth heart sound is produced in not majority of the cases in healthy individuals, but in the pathological conditions. Now, as the atrial contraction ends, atrial pressure begin to fall. Obviously, right? 0.11 is the atrial systole. 0.69 is the atrial diastole. So as the atrial contraction ends, atrial pressure begins to fall. So this decline of the fall of the atrial pressure, you can see here very clearly, produces a slight reversal in the pressure gradient across the AV valves. A change is seen as the X descent on the atrial pressure tracing. During this time, the AV valve leaflets begin to drift upward towards the closed position, a process known as pre-positioning in the preparation of the onset of ventricular contraction. So this is what we need to know, all the mechanical events, whatever is taking place during atrial systole. So the atrial systole is completed. Now the ventricles are completely filled with the blood, that is approximately 130 ml, right? Now the contraction of the ventricle should begin. So we are entering into the next phase called as ventricular systole. In the ventricular systole, The first event what we have is called as isovolumetric ventricular contraction, or in simple terminology, we can call it as isovolumetric contraction. So this ventricular systole lasts about 0.27 to 0.30 seconds, but I am taking the fixed reference value of 0.27 seconds. And during this time, the ventricles are contracting while the atria are in diastole, right? The atria entered into the diastolic period, but the ventricles are contracting. The very first phase of the ventricular systole is the isovolumetric contraction, which is remarkably very short, only about 0.05 seconds, but critically important for building the pressure that will eventually eject the blood into the arteries, the aorta or the pulmonary artery. So the sequence begins immediately after the QRS complex appears on the ECG, and this QRS complex represents ventricular depolarization, and it occurs just before the ventricles actually start contracting. I already mentioned you that mechanical events will be seen after the electrical events. That is the reason the contraction is a mechanical event which can be seen just immediately after the QRS complex tracing on the ECG. So as the depolarization wave sweeps through the ventricular myocardium, the ventricular muscle fibers begin to contract. But at this stage, both the atrioventricular valves, the mitral and the tricuspid, and the semilunar valves, that is the aortic and pulmonary, are closed. As you can see over here very clearly, in the beginning of the isovolumetric contraction period of the cardiac cycle, what is happening? The pressure inside the ventricles is greatly increasing, and the pressure in the atria drops because atria is under the diastole and the ventricle is in the systolic period. As the ventricular contraction begins, as the pressure in the ventricle rises, as in the pressure in the atria drops, there is a difference in the pressure between the ventricle and the atria responsible for the closure of atrioventricular valves. That is, closure of tricuspid valve and closure of mitral valve. And this closure occurs slightly before the tricuspid valve closes on the right side. Always remember, the valves close first where the pressure gradient is higher, and only after the valve will be closed where the pressure gradient will be lesser. So that is the reason always closure of the valves on the left side is seen first and on the right side is seen next. That is the reason whenever we talk about the heart sound, first heart sound develops because of the closure of mitral valve and the tricuspid valve. So which valve is closing first now? Mitral valve is closing first. After that, there is a closure of the tricuspid valve. So that is the reason whenever we talk about the first heart sound, we have two components. One is the mitral component, another one is the tricuspid component. Okay, these two components mix together to produce one sound called as first heart sound. So this is how the first heart sound is produced by the closure of atrioventricular valves. And this is typically the longest and the loudest heart sound and extends into the early part of the ejection phase, not just into the isovolumetric contraction. The sound extends towards the early part of the ejection phase also. So on the left atrial pressure tracing, this movement is also marked by the appearance of C wave, which reflects the slight bulging of the mitral valve back into the atrium under the force of ventricular contraction. Meaning, whenever the ventricles contract, so whenever there is a bulging of the valve towards the atria, the volume of the atria decreases, so pressure increases. So that is marked as a C wave. That is how we have to think about the pressure tracing curve, right? So during isovolumetric contraction, the muscle fibers are generating maximum tension, but they are not shortening. The name itself says that isovolumetric. So same volume, same length, but the force of contraction within the myocardial fibers is greatly increased. The tension is greatly increased without change in the volume or without change in the length. So that is the reason we call the contraction is isometric in terms of fiber length. So, in this particular phase, I have already told that the force of contraction is greatly increased. There is isometric contraction. So, this is an energy intensive movement. So, whenever the tension within the myocardial fibers is greatly increased, it needs lot of oxygen. So, that is the reason we call this is the period of highest oxygen consumption of the cardiac cycle, because the myocardium is developing maximum tension against the closed chambers. Remember, this is the time where there is a maximum demand of oxygen to the myocardium. And hemodynamically, if we see, the changes whatever we see are very dramatic. So, the left ventricular pressure climbs rapidly from 8 millimeters of mercury, that is before the beginning of isovolumetric contraction, the pressure is 8 millimeters of mercury. Once the isovolumetric contraction develops, once the tension within the cardiac muscle fiber is greatly increased, it reaches to around 80 millimeters of mercury, which is the pressure needed to open the aortic valve or maybe the pulmonary valve on the opposite side, but the pressures are different because I'm always referring toward the left ventricle. Whenever we talk about the right ventricle, the pressure increases from 5 millimeters of mercury, roughly about 25 millimeters of mercury. So, whenever the pressure inside the ventricles exceeds the pressure of the aorta and the pulmonary artery, I'm repeating again, remember this point very clearly, whenever the pressure inside the ventricles exceeds the pressure of the aorta and the pulmonary artery, whenever it reaches above 80 or above 25 millimeters of mercury in the second half of the isovolumetric contraction period of the cardiac cycle, preparing for the opening of the pulmonary valve and the aortic valve, right? These two valves will open. After these two valves will open, we can call it as there is an end of isovolumetric contraction and beginning of the ejection period. So, in this particular isovolumetric contraction, I have already mentioned about the length of the muscle fiber, which is responsible for the increase in the tension, and this increase in the tension is responsible for the great increase in the ventricular pressure. And what about the volume? And the ventricular volume remains constant at their end diastolic volume, right? Because all the four valves are closed. There is no way the blood can escape from the chamber, right? So, at the end diastolic volume, what is the total volume which is present inside the ventricles? 130 to 150 ml, right? Typically around 130 to 150 ml in each ventricles, right? Although the individual variations can be seen, but we will take a reference point as 130 ml. So, volume is constant, 130 ml. Length of the muscle fiber does not change. Pressure inside the ventricle is greatly increased, and the tension within the cardiac muscle fiber is greatly increased. And whenever the pressure in these ventricles, that is in the left ventricle and the right ventricle, exceeds the pressure of the aorta and the pulmonary artery, prepares for the opening of these semilunar valves. Remember this point? So, this is what is happening in the isovolumetric contraction period of the cardiac cycle. So, after the isovolumetric contraction period is over, the valves will open, right? After the valves will open, what will happen? The blood will be ejected from the ventricle into the arteries. For example, when we talk about the left ventricle, that is from the left ventricle into the aorta, right? So, after isovolumetric contraction period of the cardiac cycle, and next very important event of the cardiac cycle is the rapid ejection phase. We call simply it as rapid ventricular ejection. So, again I will repeat the point, listen carefully. Once isovolumetric contraction has done its job, what is its job? To increase the pressure inside the left ventricle and right ventricle above the pressure of the aorta and the pulmonary artery. That is its job, and it is done perfectly, right? As the left ventricular pressure has risen just above the aortic pressure, once it crosses just above 80, the aortic valve swings open. This opening is the exact moment we define as the start of the ventricular ejection. Remember, the opening of the aortic valve is the beginning of the ventricular ejection period. From here, the left ventricle still continue to build pressure. Don't just stop at 80. It will keep on increasing, maximum up to 120 millimeters of mercury. So, ventricle still continues to build pressure, but at a slower rate, from 8 millimeters of mercury to 80 millimeters of mercury. Opening of the valve from 80 millimeters of mercury to extra 40 millimeters of mercury, that is reaching up to 120 millimeters of mercury. That is the reason I am calling it as a slower rate, reaching at its peak value about 120 millimeters of mercury before beginning to fall. That is the reason, guys, whenever there is an ejection of the blood from the left ventricle into the aorta, the left ventricular pressure rises from 8 to 80, from 80 to 120. So that is the reason the pressure in the aorta also rises from 80 to 120 millimeters of mercury. Remember, because the pressure should be equal whenever the blood is ejecting from high pressure area to the low pressure area, the movement will be little bit slower till the pressures will become equal. So as the blood enters into the aorta, the aortic pressure also rises from 80 millimeters of mercury to 120 millimeters of mercury. So let me tell you one of the interesting point over here. An interesting point here is that the pulmonic valve on the right side of the heart opens slightly earlier than the aortic valve. This means that the isovolumetric contraction phase is slightly longer on the left side when compared to that of the right side, meaning longer at the left ventricle, because it needs to overcome the higher aortic pressure compared with the lower pulmonary arterial pressure, right? Because to overcome the 25 millimeters of mercury on the right side is much easier when compared with to overcome the 80 millimeters of mercury pressure with the aorta and the left ventricle. During this rapid ejection phase, the ventricular muscle fibers are shortening forcefully. The left ventricular volume drops. Why? Because the ventricle is ejecting quickly the large amount of the blood which is expelled into the aorta. In fact, this is when most of the stroke volume is delivered, and this is mainly driven by the apical impulse, because we call it as apical beat, where the maximum thickness of the myocardium can be seen, that you can sometimes palpate clinically also. So because the rate of the blood being ejected into the aorta is faster than the rate of the blood is draining from the aorta as well as into the peripheral arteries. So the blood is ejecting from the left ventricle to the aorta is more, and from the aorta into the peripheral arteries is less. So there is a jam of the blood, what we can see in the aorta. So from 80 millimeters of mercury, as the pressure from 120 millimeters of mercury is coming from the ventricles into the aorta, the pressure in the aorta also will be raised from 80 to 120, because sudden rush of the blood is seeing into the aorta, right? So that is the reason, guys, the aortic pressure rises steeply during this particular period. So meanwhile, the mitral valve remains closed, as you can see here, right? The mitral valve remains closed, and the left atrium quickly begin filling with the blood coming from the pulmonary veins. As the atrial chamber fills, its pressure also rises, giving rise to the V wave on the atrial pressure tracing. And this V wave represents passive filling of the atrium against the closed AV valves. Remember this point very clearly. So I am integrating every electrical or mechanical event to the various graphs what we will study in the cardiovascular physiology. Now, on the ECG, this phase corresponds to the isoelectric ST segment, which is the period between the ventricular depolarization and ventricular repolarization, and extend into the beginning of the T wave when the ventricles start to repolarize. And this phase is pretty short, roughly about 0.13 seconds, but it's the heart highest output movement, propelling the blood forcefully into the systemic and pulmonary circulation before the pressure start to equalize and the ejection slows down. Now the rapid ejection phase is complete. So after the rapid ejection phase, the next event of the cardiac cycle is called as reduced ejection phase. So after the burst of rapid ventricular ejection, the heart moves into a quieter, more gradual stage called as reduced ejection phase, lasting about 0.09 seconds. Here, the ventricles are still contracting, but the rate of blood being expelled slows significantly. This deceleration happens because the force of contraction is waning as the ventricular muscle fibers begin to relax, and the pressure gradient between the ventricle and the greater arteries is narrowing. So this phase is sometimes linked to what we call as the basal beat, reflecting a slower, sustained muscular shortening. So in simple terminology to explain, apical beat, there is a maximum force of contraction responsible for rapid ejection. The basal beat, whenever the base of the heart contracts, then the muscle thickness at the base is less, so force of contraction exerted is also less, so amount of the blood which is ejected is also less and at a slower phase. So apical beat, rapid ejection; basal beat, reduced ejection. So during this period, the left ventricular volume continues to fall because maximum blood is already ejected in the rapid ejection and some amount of the blood is already ejected in the reduced ejection, but at a slower pace where compared to that of the rapid ejection, right? So it eventually reaches to its minimum volume is about 40 ml, what we call it as end systolic volume. But again, end systolic volume is approximately between 40 ml to 60 ml. So for example, if the end diastolic volume is 130 ml, if the end systolic volume is 40 ml, then the ejection of the blood is totally about 90 ml, that is the stroke volume. But if the end diastolic volume is 130 ml and end systolic volume is 60 ml, then the total stroke volume is about 70 ml. That is how you need to remember, right? So when I say that after the ejection of the blood is completed in the rapid ejection phase as well as in the reduced ejection phase, and the volume is about 40 ml, right? We reach at the end systolic volume. This means that from the starting end diastolic volume of about 130 ml, roughly 90 ml of the blood is ejected. That is, the stroke volume has been ejected. So stroke volume is also not constant. Some authors may take 70 ml and up to 90 ml, and both are correct. So while ventricles are finishing their work, what is that? Contraction, right? Rapid ejection and reduced ejection. The left atrium is quietly filling because left atrial filling continues till the entire diastolic period of the atria, which is 0.69 seconds, because atrial contraction is only 0.11, right? So left atrium is quietly filling with the blood returning from the pulmonary veins because the mitral valve is still closed, as you can see very clearly, and this filling leads to progressive rise in the left atrial pressure, which further enlarges the V wave in the left atrial pressure tracing. So this is an important point because the atrium is preparing for the next cycle while the ventricle is still on the tail end of the systolic phase, that is the reduced ejection phase. So from a pressure standpoint, the left ventricle is interesting here, right? It reaches the peak pressure around 120 millimeters of mercury from 8 millimeters of mercury before the isovolumetric contraction. Now, from this particular phase, the pressure gradually declines as the ejection slows down until the moment when the aortic valve finally closes, marks the end of systole, right? At the same time, whenever the aortic valve is closed, we call it as the beginning of diastole. So whenever we see the closure of the aortic valve, we call it as end of systole and beginning of diastole, and majority of the authors consider the closure of these semilunar valves is the beginning of the diastole. So remember guys, closure of the semilunar valves, aortic valve as well as the pulmonary valve closes at the protodiastolic period of the cardiac cycle, which is immediately after the reduced ejection phase, which is not the part of the contraction phase, but which is the part of the relaxation phase of the ventricles, right? So the finally closes, marking the end of systole and beginning of the diastole. On the right side of the heart, similar pattern occurs with the pulmonary valve also. So on the ECG, the end of T waves corresponds to this phase, representing the completion of ventricular repolarization. And this electrical recovery sets the stage for the muscle fibers to relax fully and to be ready for the next isovolumetric contraction phase, we can say. Till that time, it is quiet. So in summary, we can say that the reduced ejection phase is the heart cool down lap. Pressure is falling. Volume is reaching to its lowest point, and the atria are topping up with the blood, and the ventricles are preparing to transition from contraction to the relaxation phase. So this is what is happening in the ventricular systole. And in the ventricular systole, we have discussed about 3 phases: isovolumetric contraction, rapid ejection, and reduced ejection. After the reduced ejection, 90 ml of the blood, or we can say 70 ml of the blood, is out. And now what is left inside the ventricles is the end systolic volume. Meaning, one point I need to tell you before we start the diastolic period of the cardiac cycle. Heart never gets emptied. If it gets emptied, it will collapse. Always some amount of the blood is always present in the ventricular chambers. After the ejection is completed, rapid ejection and reduced ejection, out of 130 ml, if 90 ml is going as a stroke volume, still 40 ml is left. So always some amount of the volume of blood is present inside the ventricular chambers, right? So now this is the end of the systolic period of the cardiac cycle. Now we are entering into the most famous and longer, which is the diastolic period of the cardiac cycle. So as I already mentioned that, what is a transition phase between systole and diastole? End of systole and beginning of diastole is marked by closure of pulmonary valves as well as aortic valve, right? Which are semilunar valves. This is called as protodiastole, which itself says that it is the beginning of diastole, or some authors we call it as end of systole. But still, even though we call this as end of systole, reduced ejection phase is called as end of systole. But this protodiastole belongs to the diastolic period of the cardiac cycle. Remember, diastolic period of the cardiac cycle. This is the first step of the ventricular diastole, you should remember. So now, the moment ventricular systole draws to a close, the heart doesn't simply switch off into a relaxation. Instead, it transitions through a very short but important period called as protodiastole, which is lasting for about 0.04 seconds. This is the first phase of the ventricular diastole, and it sets the stage for full relaxation and filling. So let's discuss in more detail. So by the end of ejection phase, the pressure inside the ventricles and the pressure inside the greater arteries, that is aorta and the pulmonary artery, are almost equal. When the pressures are almost equal, the valves will not open or will not close. So if you want the semilunar valve to close, the pressure inside the ventricles should drop when compared to that of the pressure in the greater arteries, right? So, but for the semilunar valve, that is the aorta and pulmonary valve to close, the pressure in the ventricles must drop below the pressure in these arteries. Remember this point. Then only the semilunar valves will close. So, there will be a slight drop in the ventricular pressure, not maximum drop. There will be a slight drop in the ventricular pressure. Is all it takes for the semilunar valve to snap shut. This is a mechanical event. Closure of the semilunar valves because slight decrease in the pressure in the ventricles compared to that of the aorta and the pulmonary artery, responsible for the closure of the semilunar valves, and this closure of the semilunar valves produces the second heart sound, that is S2, and this sound can be appreciated during auscultation and marks the end of systole and beginning of diastole. So here one point I want to tell very clearly. S1 is a systolic sound and S2 is a diastolic sound. Why? Because S1 occurs during isovolumetric contraction period of the cardiac cycle, that is beginning of the isovolumetric contraction period of the cardiac cycle, where the pressure inside the ventricles greatly increased when compared with the pressure in the atria, responsible for the closure of atrioventricular valves, produces first heart sound. And here in the protodiastolic period, which is the first phase of the ventricular diastole, because of the closure of the aortic and the pulmonary valve, responsible for the development of S2, that is the reason S1 is the systolic sound and S2 is the diastolic sound, we can say, right? So if you were to look at the aortic pressure tracing, you will notice a small upward deflection immediately after the valve closure. So the dicrotic notch or incisura. So this notch occurs because the aortic valve closes and a brief backward flow of the blood strikes against it, causing the pressure blip before the blood continues forward into the systemic circulation. So everything has a meaning and some correlation towards the pressure curves, whatever we study in the cardiovascular physiology. So on the cardiac muscle action potential curve, you see the cardiac action potential curve, there's a slight decline in the pressure corresponds to a small dip, slight decrease in the ventricular pressure, I told you, right, which happens in the protodiastolic period of the cardiac cycle, which is phase 1. Phase 0 of the action potential graph represents isovolumetric contraction, rapid ejection and reduced ejection. So after the reduced ejection, you can see the amplitude of the cardiac action potential is at peak, and the slight drop, whatever you are seeing, we call it as initial repolarization in the cardiac action potential, which is a phase 1, which corresponds to the protodiastolic period of the cardiac cycle. During phase 1, closure of semilunar valves responsible for the production of second heart sound, and same thing is happening in the protodiastolic period of the cardiac cycle. So everything is interrelated over here, right? Which is the early repolarization phase, phase 1, protodiastole of the cardiac cycle, right? And the atrial pressure curve, you might notice a few subtle vibrations as the valve closure transmits mechanical energy back into the atria, right? And another important physiological note I want to tell over here, coronary artery filling begins here. Always we discuss whenever we talk about the coronary circulation happens during diastole but not in the systolic period. That is wrong. Actually, the coronary arteries gets its blood supply during entire period of the cardiac cycle, but maximum during diastole, less during systole. And that is also not same for both the ventricles. Left ventricle approximately receives maximum blood flow through the coronary arteries during diastole, that is 60 to 70%, and only 30% during systole. But when we talk about the right ventricle during systole and diastole, it receives 50%. So that is the reason whenever there is a myocardial ischemia, the maximum effect is on the left ventricle but not on the right ventricle, right? So during systole, the contracting myocardium, during systole what happens? The myocardium is contracting. The contracting myocardium compresses the coronary vessels. So that is the reason the blood supply to the myocardium during contraction is less. Whenever it compresses the coronary vessels, limiting blood flow. And once the ventricle pressure starts to fall in protodiastole, it's releasing. The coronary arteries are able to open up again and receive blood. This is why majority of the coronary perfusion occurs during diastole but not at the systole. But you should not remember a few points, or few authors sometimes may say that completely the myocardium receives its blood supply during diastole. That is absolutely wrong. Yes, it received during diastole, but maximum during systole also it receives some amount of blood. But again, when I talk about the left ventricle and right ventricle, it's different. When I talk about the left ventricle, 70% of the blood it receives during diastole, 30% during systole. But on the right ventricle, 50% during systole and 50% during diastole. Why? Because the compression of these coronary arteries on the right side of the heart is less when compared to that of the left side of the heart. So it receives equally during systole as well as diastolic period of the cardiac cycle. So protodiastole might be very brief, but it is a very critical handover movement. The ventricular contraction ends, pressure takes over, valves close firmly to prevent the regurgitation, and heart prepares for the next phase called as relaxation. So after the protodiastolic period of the cardiac cycle is completed, we are entering into the next phase of the cardiac cycle, which is called as isovolumetric relaxation. That is the reset phase before filling start, we can say. So following closure of semilunar valves, now you can see the position of the heart very clearly over here. Following the closure of semilunar valves, which we just discussed in the protodiastolic period of the cardiac cycle, the ventricles enter a short but essential period called as isovolumetric relaxation, which is lasting about 0.08 seconds. And the name itself tells you exactly what is happening in iso, meaning same. Volumetric refers to the volume. So during this particular time also, the volume of the blood inside the ventricles remain constant, and there is no filling, no ejection, because all four valves are closed. So the AV valves, mitral and tricuspid, are still shut from the previous contraction, and the semilunar valves, aortic and pulmonary, have just snapped closed during protodiastolic period. All the valves are closed. With all four valves closed, it relaxes as the closed chamber, right? Even though no blood is moving in and out, the ventricular muscle fibers are relaxing rapidly. This causes a sharp fall in the ventricular pressure. The ventricular pressure drops is purely because of the result of not the volume, because of the relaxation of the muscle, but not because of the change in the volume, right? So if you were to watch the pressure tracing, you would see a steep downward slope during this particular phase very clearly over here. So now on ECG, this period corresponds to the beginning of the isoelectric segment called as TP segment, a time when the ventricles are electrically quiet, preparing for the next depolarization cycle. And the phase ends when the ventricular pressure falls below the atrial pressure, which causes the AV valves to open. Remember, this phase ends when the pressure falls below when compared to that of the atrial pressure. So now ventricular pressure is low and atrial pressure is more. Whenever the ventricular pressure is low and atrial pressures are more, responsible for the opening of atrioventricular valves. So when the atrioventricular valves will open, what happens? There is a sudden rush of the blood into the ventricles, because till now the atrial is keep on filling from the pulmonary veins as well as from the vena cava, right? So the atria are filled now. So once the atria are filled, because of the opening of the valves, there should be a sudden rush of the blood, where we call it as a filling phase, right? But here in this particular phase called as isovolumetric relaxation, nothing is happening. Only the pressure drops to its original volume, that is approximately in the left ventricle we can say 8 millimeters of mercury. But when compared with the left atrium, which will be 10 or 12 or sometimes toward the 15 millimeters of mercury also, this pressure difference will be created in this particular phase, right? So now from the functional standpoint, we can say isovolumetric relaxation is crucial, that it ensures the ventricle complete their relaxation before the next filling phase begins, allowing the heart to optimize ventricular filling and maintains the efficient stroke volume, right? So now by this we completed the relaxation phase, that is ventricular relaxation. After the ventricular relaxation is completed, I told you that pressure in the ventricle drops when compared to that of the pressure in the atria, responsible for the opening of atrioventricular valves. Now, after completing the ventricular relaxation, now we are into the next phase of the cardiac cycle called as rapid ventricular filling. So this is the first rush of blood into the ventricles, we can say. So as soon as the isovolumetric relaxation ends, an important pressure shift takes place. The left ventricular pressure has now fallen just below the left atrial pressure, and this difference in the pressure is a signal for the mitral valve swing open, and this movement when AV valve opens marks the official start of the ventricular filling, because the atrium has been steadily collecting blood from the pulmonary veins during ventricular systole and now holds a significant volume, and once the mitral valve opens, blood flows rapidly into the ventricles, and this happens because the pressure gradient is high and the ventricle is relaxed and compliant, ready to receive the incoming volume. And during this particular phase, the left ventricular pressure actually continues to fall for a short time, moving in parallel with the left atrial pressure. Why? Because the ventricular muscle fibers are still completing relaxation. Even a filling starts, despite the fall in the pressure, the ventricular volume rises sharply. This is the rapid part of the ventricular filling, we can say. And in the atrium, the opposite is happening. The left atrial volume decreases quickly because there is a sudden rush of the blood from the atria into the ventricle as it empties into the ventricles, and the left atrial pressure falls from the peak of the V wave, and this fall in the atrial pressure is recorded as a wide descent on the atrial pressure curve, right? So this is what is seen over here. I want to tell you another important mechanical event. What is happening in the rapid filling phase? There is a sudden rush of the blood from the atria into the ventricles. For example, we call it as a through the mitral valve from the left atrium into the left ventricle. So while the blood is flowing from atria to the ventricles, it is passing through the chordae tendineae. So because of the sudden rush of blood towards the ventricles, it pushes or hits the chordae tendineae, and the chordae tendineae starts vibrating, right? So because of this rushing, an important sound event can occur, that is the third heart sound, S3. So third heart sound, S3, is because of filling of the ventricles, that is in the rapid filling phase. So especially in children and younger adults, S3 may be perfectly normal but reflects the rapid filling of compliant ventricle. But in adults over 30 to 35 years of age, However, a distinct S3 usually suggests a pathology, often due to increased filling pressures or reduced ventricular compliance, examples like in the heart failure. So that is the reason you always have to connect each and every event of the cardiac cycle, whether it is the interatrial pressure curve, whether it is the heart sound, whether it is the ECG, everything. So like that, for every event, we are discussing about all these events. So even in this particular event also, we have to talk about the ECG. So on the ECG, this filling period corresponds to the isoelectric TP segment, a quiet electric phase when the ventricles are not depolarizing or repolarizing, they are simply relaxing and filling. So in summary, in this particular phase, we can say that the rapid ventricular filling is the first major flow phase of the diastole and the pressure-driven high flow event that primes the ventricles for the remaining filling phases, ensuring they are ready for the next heartbeat, right? So maximum filling happens during this particular period, guys. So why I'm calling it as maximum filling? Because after the rapid filling phase, we have the next phase of the cardiac cycle called as the reduced filling phase. And this reduced filling phase, we also call it as a diastasis, right? So after the rapid ventricular ejection phase is completed, the movement of the blood from atria into the ventricle begin to slow down. And this slower phase is called as diastasis, and it usually lasts about 0.19 seconds. So though its exact duration can vary depending upon the heart rate, but in this particular period, the pressure gradient between the atria and ventricles is much smaller when compared to that of the rapid filling phase, but the blood still flows across the open AV valves. But now it's mainly driven by the continuous venous return from the greater veins in the atria and then into the ventricles. So because this inflow is slower, the left ventricular volume increases only gradually but not rapidly. Along with that, the left ventricular pressure also rises very slightly because of the slow increase in the volume, reflecting the slower addition of the blood to the ventricles from the rapid filling phase. And meanwhile, in the systemic circulation, the aortic pressure continues to decline slowly. This is because the blood is draining from the aorta into the peripheral arteries during this particular time, and there is no fresh ejection from the ventricles to replenish it. So hemodynamically, this phase is marked by a gentle simultaneous rise in the atrial pressure, ventricular pressure, venous pressure, along with a slow climb of the ventricular volume, right? So this essentially the quiet period of the diastole before the atrial kick adds the final volume into the ventricles, right? After the reduced filling, we have the final filling of the ventricle called as atrial systole. We have already discussed in the beginning of the cardiac cycle. So in this particular phase, if you see the ECG, this diastasis corresponds to the end of the isoelectric TP segment, which is the electrically silent period between the heartbeats before the next P wave signals the onset of atrial depolarization and contraction. So this reduced filling phase is very, very important because it gives the ventricles time to complete passive filling without any active contraction from the atria, a period that can shorten significantly when the heart rate increases. Because whenever heart rate increases, the diastolic period decreases. When the diastolic period decreases, the reduced filling phase decreases. When the reduced filling phase decreases, the total volume of the blood which can be filled inside the decreases. So automatically end diastolic volume decreases. So whenever the end diastolic volume decreases, obviously the cardiac output decreases, stroke volume decreases. So this is how every movement, everything is interrelated with each other, right? So after this reduced filling is completed, now the atrial kick is seen, called as atrial contraction, and the cycle repeats, right? So after completing the previous ventricular filling phases, the cycle returns to the atrial systole, which is again about 0.11 seconds. Here the atria contract one final time before the ventricular systole, giving so-called as atrial kick, the last portion of the blood that tops to the ventricles before the contract. Immediately after this, the cycle begins again, and the same cycle is repeating again and again, and all these events are repeating again and again. So this is what is about the mechanical, electrical, and all the events whatever we discussed in the cardiac cycles. Now, I want to tell you a few important observations about timing and valve events. One crucial thing to remember is that during both isovolumetric contraction and isovolumetric relaxation, all four heart valves are closed, if you remember, right? During isovolumetric contraction also, the contraction happens with the closed chamber. Even in isovolumetric relaxation also, relaxation happens with the closed chamber. So blood is not moving in and out of the ventricles during these intervals. There is never a point where the valves are open at the same time. All valves never open, but all valves are closed at isovolumetric contraction and isovolumetric relaxation period. And another important key fact I want to tell you here, that as the heart rate increases, as I already explained during the reduced filling phase, as the heart rate increases, for example, during exercise, what will happen as the heart rate increases? Systolic period should remain constant in majority of the time, 0.27. The diastolic period is 0.53. Maybe the systolic period will become from 0.27 to 0.25. But what is the duration of the cardiac cycle? 0.8. So when the heart rate increases from 0.8, it will be up to 0.60 or 0.50 also sometimes. So majority of the compromise will be done by the diastolic period, right? So diastole shortens. So diastole shorten disproportionately more than systole. So this means that there is a less time for the coronary artery filling. As I already mentioned, especially when we talk about the left ventricle, coronary artery filling is happening 70% of the time during diastole and 30% of the time during systole, right? But especially during the increase in the heart rate, during tachycardia, whenever the diastolic period is compromised disproportionately, obviously the ventricular filling will be affected, right? Since the coronary perfusion primarily comes during diastole, 70%, especially when we talk about the left ventricle but not the right ventricle. So in people already with the narrowed coronary arteries, such those with atherosclerosis, this reduced perfusion can cause angina pectoris during exertion, because during exertion heart rate increases, diastolic period decreases, reduced perfusion to the myocardium. Already if the patient is having atherosclerosis, there will be further reduction. So if there is a approximately 75% of the reduction of the coronary blood supply to the myocardium responsible for the development of angina pectoris during exertion. So this is how the patients develop angina pectoris during exertion. So that is the reason, guys, whenever you understand each and every event of the cardiac cycle very clearly, carefully, about the atrial pressure curve tracing, about ECG, about the heart valves, whenever you connect with the action potential graph, whenever you interrelate each and everything, the entire cardiology will become much, much easier for you, right? Yeah. So I want to tell you another important point here. An increase in myocardial contractility, whether naturally from catecholamines or therapeutically from the drugs like digitalis, can reduce the end systolic volume and increase both stroke volume and ejection fraction. In contrast, in a severely weakened and dilated heart, the residual ventricular volume can be much larger when compared to that of the stroke volume. So this is what you need to know about the clinical aspects related to the cardiac cycle also. So this is what we need to know in detail about all the events of the cardiac cycle.